Assalamualaikum doctors. In this video, I am discussing about the Kawasaki disease video stations. So Kawasaki disease, we know the clinical features. There is red blood spot in eyes like conjunctivitis, red cracked lips and red tongue. Okay. So there is strawberry tongue, we know, and cracked lips. They have red swollen hands. There is peeling of the hand skins, then red swollen feet, high grade fever, rash involving the much of the body. Okay, rashes there is present. So how can the differentiate? It is a mucocutaneous lymph node syndrome. Remember, it is a mucocutaneous lymph node syndrome. The DD of Kawasaki disease we can keep like COVID, PIMS, pediatric inflammatory multisystem syndrome, measles, rubella, roseola infantum, scarlet fever, anaphylaxis, and drug reactions. History, we ask concept of the rash distribution. Where start first? Is it painful, itchy, elevated on the surface? Any other family member has the same rash. Fever for how many days? Very important. Fever for how many days? We know 5 days more than is one of the criteria. Erythema at the site of BCG mark. This is also we need to ask. Uncommon erythema at the site of BCG mark. Any eye redness and associated with purulent discharge. Any neck swelling. We know cervical lymphadenopathy, conjunctivitis. These are the features. Any mouth redness or oral soreness. So red tongue and the strawberry tongue, the features. Any edema or peeling in the fingers and toes. Any chest pain or palpitations. Very important. Chest pain and palpitation. We know complication is aortic aneurysms, Kawasaki disease. For DD, we can ask like history of any drug intake, any cough, shortness of breath, any allergic reactions, and sting bite. Examination, what we do? ABC vital, especially the heart rate and hydration status, cardiac examinations, examination of the rashes with glass test, blanchable, cervical lymph node examinations and other lymph node and eyes examinations, examination of the BCG site indurated. Okay. Investigation, remember it is a clinical diagnosis, none is diagnostic. Okay. None is diagnostic, but we do the full blood count, ESR, CRP, LFT and albumin level, urine sterile pyuria, CSF lymphocytosis, culture, urine and blood, SO titer, throat swab, virology screening if rash persists, enterovirus, parvovirus, Epstein-Barr virus, cytomegalovirus, measles and PCR, ECG, ST depression and T-wave inversion, HV. Echo, do not delay their therapy before echo. So ECG, echo, blood, CBC, CRP, ESR, culture sensitivity, urea culture sensitivity, lumbar puncture, SO titer, everything we do in investigations. Now we are going for the treatment. How can we treat? First of all, we give the aspirin. Aspirin dose is 7.5 to 12.5 milligram per kg 6 hours. Remember, aspirin is 7.5 to 12.5 milligram per kg 6 hours until afebrile or minimum 2 weeks to be decreased to 2 to 5 milligram per kg on the day for 6 weeks. Okay, 6 weeks we can give or until afebrile. IV immunoglobulin 2 gram per kg. Monitor the respiratory rate, heart rate, blood pressure. Take care of allergy. Given gradually, can be repeated if fever persists 36 hours after first dose. Monitoring IV immunoglobulin infusions. Monitor the temperature, heart rate, blood pressure and respiratory rate every 5 minutes for first 15 minutes. Then every 15 minutes for first hour. Anticipate anaphylaxis, flushing, fever, headache, shivering. If tolerated, increase the infusion rate to give total dose over remaining 10 hours and monitor hourly. If a mild reaction, stop infusion for 15 minutes, then restart at slower rate. So we are monitoring the IV immunoglobulin. We give aspirin, give IV immunoglobulin, give methylprednisolone 0.8 milligram per kg 12 hourly for 5 to 7 days or until CRP normalizes. After discussion with the rheumatology, given in high risk patients or if fever persists after second dose of IV immunoglobulin followed by prednisolone. 2 mg per kg per day, went over 2 to 3 weeks. Infliximab after discussion with the pediatric rheumatology, given in case of methylprednisolone failure. Then discharge and follow-up when fever settled, echo at 2 weeks and 6 weeks from the onset of signs and symptoms. So echo we do 2 weeks and 6 weeks, remember. When fever settles. So we are treatment giving aspirin, IV immunoglobulin, prednisolone and infliximab, and 2 weeks we are giving the echo and 6 weeks we are giving the echo signs symptoms. Now how outpatient management. If there is no aneurysm at 6 weeks, stop aspirin, no treatment, no restriction of activity, follow up after 1 year. So no aneurysm, so no, stop the aspirin, no restriction of activity after 1 year follow up. Now there is a single aneurysm but size is less than 8 mm. Single aneurysm size less than 8 mm, aspirin 2 to 5 mg per kg till the aneurysm disappear. Activity level is determined by the cardiologist and follow up every 6 months with ECG and echo. So if aneurysm single less than 8 mm, we aspirin give until it is disappear and ECG echo at 6 months. Activity restriction by the cardiologist opinion. Then multiple or giant aneurysm or stenosis, lifelong aspirin. So if aneurysm multiple, then lifelong aspirin and warfarin. Advice: avoid excessive exercise till echo appointment. Avoid live vaccine for 3 months after IV immunoglobulin. When to seek advice from pediatric rheumatology? First of all, incomplete Kawasaki. Feature suggestive of an alternative rheumatologist or inflammatory diagnosis, age less than 1 year, and failed fast dose of IV immunoglobulin. So when we rheumatology incomplete Kawasaki, failed fast dose of IV immunoglobulin, incomplete Kawasaki, fever persist, age less than 1 year. These are what are the risk factor of Kawasaki disease? First of all, age less than 1 year, shock, coronary or peripheral aneurysm features, failed IV immunoglobulin, persistent or increase of CRP despite IV immunoglobulin, liver dysfunctions, hypoalbuminemia, Kawasaki score more than 5. So these are age less than 1 year, shock, failed medical treatment, failed IV immunoglobulin, Kawasaki score more than 5, hypoalbuminemia, there is persistent increased CRP despite IV immunoglobulin, coronary peripheral aneurysms, liver dysfunctions. Regarding complete Kawasaki, fever for 5 days or more, plus 4 of the conjunctivitis, bilateral non-prudent conjunctivitis. Oral changes, that is red lips, pharynx and tongue, peripheral edema, erythema of the palms and soles, followed by discombination 10 to 14 days, rash polymorphous with no vesicular, no crust, lymph nodes, acutely enlarged cervical lymph nodes more than 1.5 centimeters. So remember polymorphous rash. So triteria polymorphous but not vesicular. The rash of Kawasaki is polymorphous, where HSP is maculopapular, blanchable rash, palpable rash. ITP is petechial purpuric rash. Here is polymorphous rash in Kawasaki. Incomplete Kawasaki is the children with fever equal or more than 5 days plus 2 or 3 triteria, infant with fever or more than 7 days of other explanations. CRP less than 30, SR less than 40 if fever persists, serial level clinical follow-up if feeling echo. CRP more than 30, SR more than 40, treat if anemia, platelet more than 4,50,000, when fever, WBC more than 15,000, elevated ALT, albumin less than 13 gram per liter, urine more than 10,000 WBC per microliter. Multiple Kawasaki may not fulfill all the above criteria. If fever less than 5 days but 4 signs above, persistent elevation of CRP, no other diagnosis and suspicion of Kawasaki disease. So atypical Kawasaki, if less than 5 days fever, there is persistent elevation of CRP, fever usually precedes the other signs, unresponsive to antipyretics, common features irritability, erythema at the VCG site. Other features are aseptic meningitis, uveitis, cough, vomiting, diarrhea, abdominal pain, urethritis, arthralgia, arthritis. Examine for aneurysms in other areas. Example, axillary. Kobayashi score. What is Kobayashi? More than 5. Age less than 1 year equal 1. Less than 4 days of the illness equal 2. Platelets less than 300 into 10 to the power 9 per liter equal 1. More than 80% of neutrophil equal 2. CRP more than equal 100 milligram per liter equal 1. Sodium less than 133 millimole per liter equal 2. ALT more than or equal 100. International unit per liter equal 1. So this is Kawasaki disease. Thank you.